I'm Mildred Solomon, the president of the Hastings Center, an independent nonprofit research institute that looks at ethical issues in health, healthcare, life sciences research, and increasingly at the nexus of where life science advances are impacting the natural world. This is a recorded portion of a public, this is the public portion of a meeting of the Hastings Center Advisory Council. Our advisors are highly accomplished leaders in just about every sector that you can imagine: healthcare, national and local government, environmental stewardship, finance, science and the social sciences, and law. I've already welcomed the advisors in the room, so I want to welcome the people who are watching us distally. It's exciting to be developing new strategies to share the exciting ideas that occur in our library here in the beautiful central Hudson River Valley with an audience that is beyond our location. And we've been able to do this through the very generous gift of two of our board members, Frank Trainer and Andy Adelson, and I want to thank them for this growing capacity. The Hastings Center is world famous for identifying and analyzing stubborn, fascinating, and controversial questions. One of the most controversial questions that our nation has confronted in recent years pertains to what kind of healthcare delivery system we should have and how it should be funded. What do we owe to one another in terms of healthcare? And if there is an obligation, how should it be expressed? In what manner should it be funded, for example? To help us examine this question, we have two preeminent scholars, Professor Jim Morone, who's a political scientist on the faculty of Brown University. He's an expert in health and social policy, and he was honored by the Robert Wood Johnson Foundation with an Investigator Award, a very prestigious award for political scientists and social scientists of many kinds. And Michael Gusmano, who is a research scholar who is building the health and healthcare area of the Hastings Center and is also a prominent political scientist. Doctors Morone and Gusmano have worked together to plan this session, and Jim is going to frame the conversation with some preliminary remarks. He's going to talk for about 30 minutes on the very different moral conceptions that we Americans have about what citizens and government owe one another and where they have come from historically and how they account for or undergird the political divisions that we see around these topics. And then after Jim's remarks, Michael and Jim are going to help facilitate a conversation amongst all of us here in Garrison. Okay. Professor Morone?
Thank you. So it's a pleasure to be back, to be called back after all this time. Let's take a quick look at our roadmap. First, I want to give you a bit of context, and then a bit of a backing up to get a running start. Just what are we trying to do when we think about addressing healthcare problems? What's our problem? Third, I want to particularly focus on the values question, which is, I think, a place where the Hastings Center has always been incredibly valuable for the national discussion. Fourth, I want to look quickly at potential solutions, then take a look at Obamacare and the story of its implementation, and perhaps end on a positive note about our politics. Part one, just a quick introduction to frame this. I want to put American healthcare and its problems in context. If you fly into the domestic airport in Mumbai, these are pictures from there. As you step off the plane, there's a stench that assails your nose. If those of you who've done it know exactly what I'm talking about. It's the stench of human sewage. Right on the edge of the airport, as you can see in that top picture, there is a jerry-rigged slum. That slum, the subject of Catherine Boo's wonderful book on India, that slum has about 1 toilet per 100 residents. There's no running water in it. If you walk through it, what you see is this incredibly energized place where people are making things and selling things and meeting on street corners, and you can see factories, but everything goes on the street. They shave on the street, they wash on the street, etc. And that creates this terrible stench. It's a public health disaster. 750,000 people living without running water, crammed into this very small area. Why? Why don't the public officials do something? There's 2 reasons. First, the slum is illegal. They want to clear it out. And by putting in running water, it'll make the people more comfortable in a place where the people aren't supposed to be. And secondly, I was interviewing a Bengali legislator, and he said, I don't feel this way, of course, but many of my colleagues think someone has to clean out the toilets. And if we make people too comfortable, particularly the Dalits, the untouchables, they won't be willing to do the tasks no one else wants to do. So here we have a city, the 4th largest city in the world, incredibly dynamic economy, and an extraordinary amount of inequality in the middle of that city. Now, I put this slide up to frame our thinking in 2 ways. One, most of the world is dealing with problems we have solved so long ago they seem incredibly far away. Running water, for crying out loud. But secondly, we have a problem in India that makes everybody ask, well, why doesn't government do something? And that's a refrain you hear again and again in American politics and in American healthcare policy. And this whole refrain is turned around a question of societal inequality. Again, a question that Americans wrestle with. So what seems incredibly foreign and is incredibly foreign also echoes back on who we are. All right, that's my framing, my introduction. Now let's get to the problems. For many of you, this will be old hat, so I'll run through it quickly. But I want us all to get on the same page about what we're talking about when we're talking about healthcare reform. So apologies for you experts, from you many experts in the room, but let's just go through the 4 problems that all healthcare reform in the United States is meant to address. Problem number 1, healthcare costs. If you've been in the healthcare business for more than 10 minutes, you know you need lots of synonyms for going up. And there's the classic chart. Right now, 17.9% of GDP. We have put an extra percent of GDP to healthcare, every 5 years, roughly, in the United States? Uwe Reinhardt, the funniest man in healthcare policy, has a Christmas card he sends out, or used to send out, and it was a calculation for when we'll have it all, 100% of American GDP going to healthcare. I think it was, Michael, do you remember? It was 2140 or something. This will be a long-term care facility. Get rid of the books. It'll be about healthcare. And there is a certain logic to it, you see, if you project it out. I remember once when I was in grad school, Odin Anderson predicting that we would, this will tell you how long ago it was that I was in grad school, that we would hit 10% of GDP for healthcare by the year 1990, and the economists laughed at him. Oh, we're going to take action before 10%. Now we're heading for 20%. Sooner or later, we're going to take action. There's another thing about healthcare costs, and that is all nations complain all the time. Go to any country, they're complaining about healthcare costs, but they've kind of got them under control everywhere else. We are an international outlier. If you look across the last decade, the OECD average is 0.7 of 1% of GDP rise in healthcare. We, at that same moment, that same decade, went up 4%. So there is a sense that other people have, for better or for worse, with lots of caveats, gotten a handle around rising healthcare costs, and we haven't. Now look, here's the punchline about the cost debate. As long as we are putting more money to healthcare year after year relative to the rest of the economy, our healthcare system is unstable, and like it or not, we'll be debating what to do about it. So the issue does not go away until that line starts going up. You will hear lots of silver bullets. Oh, if we only do this, it'll solve the problem. And every year there's another kind of silver bullet. Don't be seduced. It's a complicated set of problems that doesn't have just one answer, like if only people would eat more yogurt and run more, we'd have or not drink or whatever, or if we only reorganize our healthcare system this or that way. There isn't a silver bullet. It's hard. And one other thing, and I say this, James, and others, many of us, income into the healthcare system is income to many of us. So there are lots of people who don't think this line is so bad at all. So every time you talk about healthcare costs, you're goring someone's sacred cow, and I put myself in that category. There are liberal and conservative answers. Punchline, other nations have solved this problem to an extent that we have not. And until we do, Democratic or Republican, every president, every administration is going to be debating health care. So welcome to the endless debate. Problem number 2, of course, the number of uninsured. It's the classic problem. There you can see the numbers. The number goes up every year. The percentage was fixed. You notice I ended the chart at 2008. That is before Obamacare. More on that in a minute. But it's a problem, this many people uninsured. And if you talk to a foreign audience, the question is always, how is it that you spend this much money and yet have so many people uncovered? What is it about the United States that we have so much trouble covering our population? And I think the answer is the logic of our insurance, our private insurance system. My favorite story along these lines comes from Judith Lave, illustrative story, an economist, a health economist, some of you will know, at the University of Pittsburgh. She went to Europe, and being an economist, didn't trust those European healthcare systems, and so decided to buy private health insurance for her family. And the insurance policy came back, and it covered her family of 4, except for her son's right leg. She looked into this and discovered that they had excluded her son's right leg because 3 years earlier he had fallen off his bicycle. They'd taken him to the emergency room, pictures of the right leg. That got into the ether, and the insurance company thought, pre-existing condition, not covered. So everybody covered but her son's right leg. What's going on in this healthcare system? The answer is really, I think, quite clear. We tell the insurers, okay, guys, get in there and compete, give the best quality for the lowest price, and you win. That's what we say. The bubble in our head is, okay, guys, insure healthy populations. If you do, you win. If you shun the sick, you're better off. That's what it takes to winning healthcare. Those are the incentives we set into the system. And so we have a system where people who demographically are likely to be sick are shunted out of our healthcare system. It's a set of perverse incentives that we've set up, and we're always wrestling with ways to try to fix the system as it's operational. Okay, costs, getting people covered. Those are explicit. They're right out front in our healthcare system. But there's something else that we talk about much less and yet is crucial, and that's our outcomes. Didn't have numbers. Okay, just pictures. If you go look at the life expectancy charts, you find something stunning, and again, something many of you have spent your lives wrestling with. The United States is, depending on the study, 35th, 38th, 41st in life expectancy at birth among countries. In fact, on almost every way we might measure population health, the United States does terribly. The CIA did a study 3 years ago of the OECD countries, and when you look at it, you say, thank heavens for Latvia, because we kicked their butt. The other 36 countries, not so much. We are 34th in teenage death. We're 35th in maternity mortality. One after another, we're way at the bottom of wealthy nations. Right this second, there's a kid being born in a Japanese hospital. And that little boy is going to live 3.5 years longer, on average, to the little boy being born right this second in New York City. And the Japanese kid is 3 times more likely to smoke. It's not fair, but there it is. If our Olympic team, if our men's Olympic team came in 35th, there would be congressional hearings. And yet, after a whole 8 years of screaming about health care, this topic barely comes up. And I think it's below the radar screen, but something really important. There's liberal explanations. We don't have national health insurance. By the way, if you're 80, your life expectancy is now number 1. So liberals say, of course, we got national health insurance for people who are 80. They're enjoying the fruits of that labor. If you're a conservative, you say, don't be silly. Those numbers, those life expectancy numbers go up for old people because all the irresponsible folks have killed themselves off. And by that time, the irresponsibles are gone. So the great debate, but something we ought to be thinking and talking about, how we do relative to other nations as we think about fixing the healthcare system. And finally, of course, quality of care. Most studies that look at our healthcare system see an incredible division between people who, between the best care in the world, point blank, no questions about it, and an enormous numbers of problems in quality systems, problems in with medical mistakes and so forth and so on. So four problems. All healthcare debates are about these four problems. There are others, but these four are central to any effort to solve healthcare in the United States. There is a meta question, and I think here's where the Hastings Center can be and has been so helpful. And the meta question is really the question about who we are. Let me back up for a second. If you look across American 20th century history, what you find is no debate has been more fierce than our healthcare debate. When Truman raised the topic in 1948, the debate was so strong that two Senate leaders, the majority and the minority leader, almost came to blows, with one screaming at the other. The Republican kept saying, "This is socialism," and the Democrat, remember it's the middle of the Red Scare, keeps saying, "Out of respect for the president, please don't call him a socialist." And they were screaming, literally screaming at one another, as reported in the newspapers of the time. Right from the start, we almost came to blows over this topic, and I don't need to tell you what's gone on in the last 6 years about healthcare. Why? Why does healthcare raise, in a way very few issues do, and right back to the 1940s when our debate began, why does it raise such fury? And I think the answer is because healthcare, almost more than any other policy issue, is a reflection of the kind of society we are, the kind of people we are. If you go from country to country and you tell people, "I think your healthcare system reflects who you are," they'll say, oh yeah, that's right, reflects our values. And Americans don't agree about their values. If you go to Germany, everybody will say, well, there's a culture of solidarity here when it comes to healthcare. We're in this together. If you go to Denmark and you try to get people to complain about the 60% tax rate they pay, they say, well, everybody gets things like health care. There's a sense of in it together, of solidarity. Some Americans feel that, absolutely. Some populations respond that they feel that. Others say, no, we're a market society. Healthcare is part of a market. And that's a very different conception, a market good as opposed to something all people deserve as a right of citizenship or as a right of membership. And then there's the whole Puritan aspect. We're individualists. You should be taking care of yourself. You should feel responsibility for your own health care. Each of these pushes in very different directions, each of these conceptions. If you go to Germany or Denmark, solidarity, that's what they say. If you go to other countries, it would be a different view. But in the United States, all these views, solidarity, market society, individualism, they're all part of the incredibly complex value system. And I think one of the things Hastings Center has always done is raise that implicit conversation to the level of direct conversation rather than being implicit. There's another piece of this that's worth noting, and that is healthcare is always about us and them, I think. In a society that's in many ways divided, particularly by race, the whole question of being in it together is a fraught issue. I'll give you a quick example. Brad predicted that I'm going to take my jacket off, and I've been polite long enough, right? During the Clinton administration, when they were debating the Clinton health plan, I had a debate with Senator Chafee. We thought it would be sort of fun for Rhode Island to have a debate that would illustrate and educate. So we did a debate. I was pro-Clinton. He was something called the Chafee plan, now known as Obamacare, but that's another story. And the first debate we had was at Rhode Island College. And I'm sheepishly will say, I was absolutely tying him in knots. I was killing him in this debate. Not indeed because I'm a better debater, I clearly am not, as you'll see in a moment, but because the front 20 rows were students who thought Clinton care was probably a little bit conservative for their taste. They would have rather had Medicare for all, but the Chafee plan was way too conservative, and they sighed and rolled their eyes and mildly hissed every time he talked. But my ace in the hole was a gray panther in the back of the room, not realizing he was hard of hearing, who said, excuse me, "That's bull!" And he used both syllables of that word every time Senator Chafee talked, and so that put a certain cramp in Senator Chafee's style. Towards the end of the debate, there's clearly a very good debate. Clinton is going to pass in Rhode Island. Senator Chafee looks sadly and says, "Professor," shakes his head. When they call you professor and not Jim, you know you're in trouble. "Professor, it's not going to work. It's not going to work. How can you ask the good, hard-working people in Cook County to go into the same healthcare alliance, the same insurance pool, as the crackheads in the city of Chicago? That's not going to work." I turned to my audience, ready to bat away this fatuous distinction, and the whole audience of liberals like, how are we? And unfortunately, I yelp, well, it's not all crackheads in the city of Chicago. They're hardworking single moms holding down 2 jobs. Yeah. Single moms, marriage. It's another problem we have to solve. At that moment, the entire audience turned. The idea that we're all in this together evaporates, and after the debate, everybody all wants to talk about what's Clinton going to do about the crackheads. What Senator Chafee so cleverly did was he said, you think, you liberals, that we're all in this together, but really, you don't even believe that. You believe there's us and there's them, and your health system has to sort that out. There are people who are blameworthy, and we're not going to pay money for the blameworthy people. By the way, in parentheses, they're a different race than you. This is a kind of implicit issue that we have to wrestle with every time we say, oh, yeah, solidarity. Not always, and not even for the liberals who claim solidarity. 2 other things about this set. One, we are now in an era of extraordinary partisanship. And that's, do I have a partisanship slide? Yeah. This is one of my favorite slides about America. It used to be, back in the 80s, that party mattered, but it certainly didn't matter as much as race, for heaven's sake, or education, or income. You can see now, this is a set of 48 questions that Pew asks, and then they sort out how you can tell how someone's going to answer the question. And what you see in the last 10 years is that if you tell me your party, I know more about your values than anything else you can tell me, including your race, your income, your education level, and your gender. It has become very hard to solve the kinds of problems I've been talking about when party division is this great. It means if you say X and I'm a Republican, I say not X. That is a stunning development in American politics, and as we argue the values underlying our healthcare system, we have to worry about that. I can't resist. It's like the old Italian joke, the little girl who comes home and says, Mommy, I want to be a prostitute. What? I want to be a prostitute when I grow up. Oh, thank heavens. I thought you said a Protestant. Substitute Democrat. Another feature of our society that we have to take account of as we discuss these issues is the levels of inequality that have developed. Here's inequality in the United States as measured by the Gini Index. We can argue about that as a measure. In 1970. What's striking is that the United States, 35.8, is in the European League, a little ahead of France, a little bit behind Japan, in the rich nation league. Notice, hold aside United Kingdom, which is incredibly egalitarian in this period. And it's all between 31 and 36 in Europe. This is a measure, if you don't know it, I multiplied by 100. 100 would be, I have all the money, no one else has any. 0 would be a country where everybody has the exact same amount. So 30s, it's a measure of how much equality and inequality there is in a society. And you can see the way the United States was. Essentially an egalitarian country, about 10% behind the most egalitarian Swedens and Canada and places like that. Look today. We have fallen out of the European League entirely and are closer now to the South American League than we are to the Europeans, and indeed closer to the most inegalitarian nation on earth, measurable Lesotho, than we are to the most egalitarian. We are a different society. I'm not saying it's good, I'm not saying it's bad, I'm saying it is an important thing for people who worry about values in politics to be aware of and to discuss. And by the way, these tables and these changes bust two myths. One, that we were always like this, land of individualism. No, we weren't always like this. And second, globalization makes inequality rampant everywhere. Those minus signs are countries that have gotten less unequal since the 1970s rather than more, and you can see these are policy judgments that every nation makes. I believe healthcare gets wrapped up in this, that when you're talking about healthcare for everyone, you're also talking about the nature, the inegalitarian or inegalitarian nature of this society. I want to give you all a chance to talk, so let me move quickly through the rest. We have four problems that I've mentioned: the cost, the access, the outcomes, and quality of care, and then some factors underlying them that really reflect what every society has to discuss. Everybody's going to get sick. Everybody's going to die. Almost everybody will be in the healthcare system. It's unlike almost any other policy system in that way, that it's so fundamental. When we discuss how to address those problems for this kind of policy area where it touches everyone, we've got deep values in play that need to be brought to the surface and discussed. I will just note that there are a number of different policy solutions that we've debated over and over and over again. One set, government solutions. The great liberal idea is Medicare, everybody gets the same. The less liberal idea is Medicaid. We sort of tailor it by state for individual people. Government solutions, obviously. There are market solutions, which Republicans have pursued for years, and then mixed solutions. I won't go into all that. We can talk about it. Markets are the Republican ideal, question mark. Now some Republicans are saying, let's not solve it through government at all, even to set up markets. Government participates in the solidarity value. And Obamacare, ever since Nixon, all our solutions, all our serious solutions, all the solutions have gotten as far as the congressional committee have mixed markets and government, private and public. I want to briefly talk about Obamacare. I'll come back to that in a second. There is, in effect, a Republican version part of Obamacare and a Democratic part of Obamacare. And I just want to give you that, and so that we're all in the same place on the Obamacare debate, and then turn it over to you. The Republican part of Obamacare. When George Bush was president, he tried very hard to get Medicare into the private sector, to privatize Medicare, that is, to let private insurance companies offer Medicare in a competitive situation. Liberals were aghast. They argue that it's too complex, that people can't trust the market actors, that if you leave it to government programs, things are much fairer. The huge irony of the Obama legislation, once you put aside all the partisanship and the screaming, is it lashes the Democrats to the Bush administration's idea of bringing markets into healthcare. That is to say, one part of the Obamacare legislation, there are many, many parts, of course. One of it is just to fix the insurance systems, change the incentives in the insurance systems. But in terms of getting access, one part is to say, as you know, look, we're going to make marketplaces where people can shop and compare products in a regulated environment. You get tax breaks if you are making less than $80,000 a year, and that will create a market, a logical market for people who don't have group health care. Notice it's really the same thing Bush wanted to do with Medicare, now done for people between $38,000 and $80,000 a year. Some Republican intellectuals are saying, wait, those marketplaces, those exchanges, those are great. Let's put Medicare in there, just as President Bush had wanted. Another Republican response, of course, has been to sue and to try to derail that part of the plan. The King versus Burrell suit, we can talk about it a little later, is precisely that, about to be decided by the Supreme Court. If you've run a state, if you don't have a state-based exchange, do the subsidies for people up to $80,000 still apply? Big debate, permitting the Roberts Court to essentially kill Obamacare for people in the middle income categories, that is not eligible for Medicaid, and buying health care on the exchanges. What it will do in effect is leave this program running in blue states and kill it in red states. We'll see what the Supreme Court has to say about that. But in my vision, that's the traditional thing Republicans had wanted. Let's get the market to operate on health care. Interestingly enough, the exchanges do that. We'll see what happens with that. But let's move on to the Democratic side. Democrats have believed traditionally in big government programs, like Medicaid, covers people in 50 states, 51 programs. The dirty, rotten secret about Medicaid is the enormous variation state by who is eligible. Programs are very, very different. For example, if you don't have children, there are only 9 states where you can get Medicaid coverage regardless of how much money you make. Let's just take one category. This is for parents of dependent children. So if you have a dependent child, your eligibility for Medicaid will vary state by state. Arkansas, it's 16% of the federal poverty line. That is, if you, in a family of 4, oops, forgot the parentheses, if you are making $3,769 last year, you're not eligible for Medicaid in Arkansas. In Massachusetts, it's 133% of poverty. In Connecticut, 191% of poverty, $44,000. Look at that range of programs. So in some places, very generous. In some places, you go a quarter of the way to the poverty line and you're no longer eligible for Medicaid. Democrats have long hated this about Medicaid. And what the Obama proposal does is say, okay, everybody, 138% of poverty, and you are eligible for Medicaid. For liberals and all the screaming, this was lost. What a major event this was. For the first time in the United States, all people in poverty are eligible for a government program. And eligible at really, Massachusetts is the model at $32,000, $32,500 for a family of 4. There were intimations of trouble right from the start. Senator Ben Nelson made a terrible fuss when Obamacare was on the floor. This is little known. I remember calling having conversations with a staffer in the Senate, and I kept saying, "What's going on with health care? You see, 60 votes you need." They had 58. Lieberman of Connecticut and Ben Nelson of Nebraska kept stopping them. Effing Ben Nelson, because Ben Nelson kept saying, no. It's only in the United States that 2 backbenchers, barely in the Democratic Party, could say, I don't like this, you can't do it. And the whole party has to adjust. There's no other system that runs like this. But what was effing Ben Nelson worried about? He has gotten a lot of press for the Cornhusker kickback, right? He made a deal that gave him special benefits. What was that deal? People don't even know. He didn't like the idea that the federal government would pay 90% of the expansion of Medicaid, and his state would have to pay 10%. And he said, in a red state like mine, people are going to want to put up the 10%. Not going to happen. And the Democrats treated this as bargaining and said, all right, we'll pay it for Nebraska. They should have listened more carefully, because what he said turned out to be prophetic. When the Supreme Court ruled 7-2, you can't let Medicaid simply require all states to go to 138% of poverty. States get to choose piece by piece. Then Ben Nelson's critique becomes trenchant. And once the Supreme Court ruled that, we get this state-by-state debate about whether to expand Medicaid. And that is probably the most interesting question for those of us interested in some level of social equity. Let me just get to what we're talking about in these states. Here's the map of where we are now. Montana just went the dark gray states. Montana just said yes. Blue states have gone. Gray states seem to be going. And look at this. I was talking about us and them. If you had slavery once upon a time, you were just not expanding Medicaid. So that's what the debate looks like right now. And yet the smart money, I've got Michael here, the smart money says it's only a question of time and most of these states will actually pass the Medicaid expansion. Why? The argument goes like this. Look, hospitals like James's system are going to be in trouble because the payments for the uncompensated care are going away. The government's payments assumed Medicaid expansion. Without Medicaid expansion, hospital systems will have a hard time caring for people who can't pay. And so the hospital lobby, not the crazy liberals, but the hospital lobby will push most states into passing. That's what happened indeed in Montana. Our hospitals are in trouble, you have to pass this, and they passed it. The other side says no. People, local Tea Parties believe in small government, don't want expansion of health care. In Montana, I was there for the debate, and someone got up and said, look, this is a gateway program. It's like a gateway drug. You put people, our young people particularly, on Medicaid, and next thing they'll be comfortable with more government. And so the debate goes on. Our hospital care system needs it, but it is more government and welfare. And so we go state by state. The surprises, a number of surprises. Blue states right in, red states resisting, and then the surprises start. Arizona, famous picture, conservative icon Jan Brewer. Conservative icon Jan Brewer says, we need this for the hospitals. I will veto every piece of legislation in Arizona until you pass Medicaid expansion. She vetoed 6 bills. The conservatives went crazy. She's no longer popular among conservatives. But she gets her Medicaid expansion. In Maine, the legislature voted for it, but Tea Party governor has been vetoing it. Since the legislature's vote is 97 plus 52 minus, 3 short of overriding his veto, we can expect Maine to pass at some point. Montana raises an interesting issue for itself. The governor agreed, pushed Medicaid expansion. The legislature was very, very close. It came down to 1 vote. This Democratic legislator voted yes, thinking he was voting for expansion, but oops, he really voted yes to send it back to committee and bury it for 2 years. I'm sorry, he said afterwards. It reminds us that we are all fallible human beings. He was a freshman. He didn't really know what he was doing. 2 years later, they come back in Montana, and they will pass it. I'll tell you in a moment. Arkansas does something interesting. They say, you know, we're a conservative state. We don't like big government programs. We'll expand Medicaid, but we want to privatize Medicaid. You liberals want expansion? We, more conservatives, want privatization. And you give the Obama administration and then Secretary of Health and Human Services a choice. We are going to fundamentally change this program. It's a private program where people shop among insurance companies. We know you don't like that Obama administration, but we're going to insist we will expand the program, but under our terms, not the Democrats' terms. And it's a really good question. It's a great debate for Democrats. Do you accept this? Sebelius says yes. New Hampshire goes in, and now a spate of other states start coming in under those terms. New Hampshire passes it. Pennsylvania passes it. Montana has now pushed a passage of Medicaid expansion that requires people under 50%, over 50% of poverty to pay a fairly significant premium. Now, that's another breakthrough. What do you do if you're a Democratic Secretary of Health and Human Services? Do you give them the waiver that says, yes, you may charge premiums for Medicaid? Notice what's happening. Agonizing choice for both Democrats and Republicans. Democrats, we take our beloved programs and we let each state make real changes. Shopping on insurance markets, imposing premiums, and so forth. Agonizing choice for Republicans. We don't like government programs. We are going to make this kind of program more amenable to us, but we're going to lock it into place. If you're a Democrat or you're a Republican, the big question is, do you go this way, yes or no? Well, here's where we stand again with Medicaid expansion. And my view is that though the debate seems intractable, and in Washington there's incredible shouting, on the states, outside of Dixie at least, we are coming to agreements that the federalism is working exactly as it was meant to work. That is, people say, for our state, this is how it feels to us. And what cannot be resolved in Washington is being resolved on the state level. Distinctly Democratic program, Medicaid, being refitted to fit Republican values. Inadvertently, this huge healthcare program may have empowered states to have debates about the nature of their healthcare system. And so I end on an optimistic note with every state in the union being purple, neither Democratic nor Republican. I'm not saying it's an inevitable future, but to me a rather hopeful future, that the debate that seemed so difficult to solve in Washington is actually being solved state by state. Would I put my house money on this being the outcome? No, but it's a plausible outcome. Is it a good outcome? If you're strongly committed to an ideological position, either Democratic or Republican, you may not like this. If you're a political scientist sort of into federalism as laboratories of democracy and going back to compromise between these parties, maybe it is a really very good outcome. Anyway, I leave that for you as food for thought. And with that, I think I've gone over my half hour, so let me just thank you, and let's get on to the conversation. Thank you.